Welcome back to the Deep Dive. This is your rapid transit system to essential clinical knowledge, especially if you're currently facing down that mountain of material required to understand infectious diseases.
Today, we are opening up Davidson's Medicine, Chapter 13. And we're not just, reading definitions. Our mission is to build a robust, immediately applicable clinical framework.
Right.
So if you're a future clinician, particularly grinding through those foundational first or second years, this deep dive is designed to distill the crucial decision points and, well, the high-stakes clinical scenarios you need to recognize instantly.
Exactly. We're providing crucial checkpoints and I think most importantly, giving you concrete memory anchors, those psychological shortcuts that really make the patterns stick in high-pressure situations.
Yeah.
We know volume is the enemy right now, so we're focused on clinical utility.
Absolutely. Understanding infectious disease patterns, how they present, why certain hosts are uniquely vulnerable, and when intervention must happen within the hour is the critical backbone of effective clinical practice. We will focus constantly on the interplay between the bug, the host, and the environment. Because frankly, you can't diagnose what you don't even consider in your differential.
Okay, let's unpack this. And we'll start where nearly every infectious process begins its journey to the clinic. The symptom that makes everyone feel terrible and demands attention. Fever.
So we have to begin with strict definitions. Otherwise, we build our diagnosis on shaky ground.
Right.
Fever implies an elevated core body temperature of more than 38.0 degrees Celsius.
And that objectivity is just.
Yeah.
It's so key. The source material really stresses that the subjective feeling of being hot or sweaty is absolutely insufficient for diagnosis. We need documentation.
We do.
Let's establish our first memory anchor right here. Fever is diagnosed only when a body temperature of over 38.0 degrees Celsius is recorded. You should think of the 38.0 degrees Celsius gatekeeper.
I like that. A gatekeeper.
Yeah, if the temperature doesn't pass that threshold, you can't officially call it a fever, no matter how miserable the patient feels.
That gatekeeper principle is vital because the associated clinical features of fever are incredibly important for localization and, frankly, for saving lives. Severe headache, especially when it's accompanied by photophobia, classically suggests meningitis. But the history of the headache must prompt a wider search.
Wide? If I see stiff neck, photophobia, and fever, I'm instantly thinking lumbar puncture.
And you should. You absolutely should. But you must also rule out what we call parameningeal infections.
Okay.
These are infections located physically near the meninges, like a severe mastoiditis or an acute bacterial sinusitis. They can cause significant localized inflammation leading to meningeal irritation symptoms without the actual meninges being infected.
So you could be hyper-focused on the CSF.
And completely miss a rapidly progressive local infection in the ear or sinuses. It's a classic trap.
That's a powerful clinical pearl.
Oh.
So the history helps you differentiate those central nervous system features from something that might be physically localized but causing immense inflammatory distress nearby.
We also note that generalized symptoms change dramatically with the host. Delirium during fever is far more common at the extremes of age, so in young children, and particularly in older people. In older folks, even a mild infection can cause profound cognitive changes. Myalgia is common in widespread viral processes like influenza, but we must also remember that it's a key symptom of severe sepsis, like meningococcal sepsis. The muscle pain itself can be a massive warning sign.
Now we move on to the true diagnostic challenge, kind of the diagnostic wilderness. Pyrexia of unknown origin, or PUO.
Yes.
This is where the diagnostic workup becomes a marathon, right? It tests both the physician's persistence and the patient's endurance.
It really does. The classic definition of PUO is indeed rigorous. A temperature above 38.0 degrees C on multiple occasions for more than 3 weeks, without a diagnosis, despite initial investigation in the hospital for 1 week.
Wow. 3 weeks of documented fever, 7 days of intense inpatient workup, and you still have no answer. That is a heavy clinical burden. Although the source notes that the definition has been softened slightly.
It has, to adapt to the speed and cost pressures of modern healthcare. Correct. The modern, more relaxed definition allows for investigation over 3 days of inpatient care, or 3 outpatient visits, or 1 week of intensive ambulatory investigation.
So the core idea remains.
The important thing is that the prolonged nature of the fever and the failure to diagnose after a systematic initial approach remain the defining features. And you have to remember, subsets of PUO are also crucial HIV-1-related immune-deficient patients, or nosocomial PUO, all have distinct differential diagnoses.
So once we meet this PUO definition, we can't just throw labs at the wall and see what sticks. What's the essential, simplified framework for our future clinicians to navigate this overwhelming differential?
We call them the PUO triple threat. The major causes, broken down by approximate prevalence, are infectious, which is often 30–40% of cases, and more likely in children and younger adults.
Okay.
Then malignancy, around 20%. And finally, connective tissue disorders, which are about 15%. The rest is miscellaneous drug-induced fever, factitious fever, things like that.
Let's delve deeper into those specific threats. What are the high-yield, infectious, and malignant causes we must anchor in memory?
Under infectious causes, in the general population, you need to think of occult bacterial abscesses hidden in the abdomen or pelvis. Also disseminated Mycobacterium avium complex, or DMAC, and cytomegalovirus, CMV, particularly in the context of immune deficiency.
And endocarditis.
Always. You must also consider endocarditis, even if initial blood cultures are negative.
And for malignancy, which ones are the big culprits?
The hematological cancers are notorious for presenting solely as PUO. This is due to tumor-related cytokine release, so you're thinking lymphoma, leukemia, and myeloma.
Right.
But don't forget solid tumors, especially renal cell carcinoma, hepatocellular carcinoma, and colon or pancreatic cancers. They can all cause paraneoplastic fevers.
And the connective tissue disorders are particularly age-dependent, which feels like a critical distinction in the history.
Absolutely crucial. In older adults, say over 50, we must rule out giant cell arteritis or temporal arteritis and polymyalgia rheumatica. Delay there can lead to blindness. Wow.
In younger adults, we look for Still's disease, a form of juvenile rheumatoid arthritis, or SLE, and various vasculitic disorders. Always remember that the older adult host is generally more susceptible to both unusual infections and non-infectious causes of prolonged fever.
Okay, so since this is a deep dive for the future clinician, let's zoom in on that initial workup for fever in a potentially infectious setting. We need to understand why these tests are ordered.
Right. The initial screening battery is extensive and it reflects that broad differential. A full blood count, or FBC, is mandatory. We look at the white cell count for neutrophilia,
For bacterial.
or lymphocytosis for viral. We look at the red cells and platelets for pancytopenia, which might suggest a bone marrow process like malignancy or a severe infection like disseminated leishmaniasis or histoplasmosis.
And you highlighted the eosinophil count earlier. Why does that specifically need to be scrutinized on the FBC?
That's a critical high-yield point. Eosinophilia, defined as an elevated count above 0.4 by 109 per liter, is a massive red flag for parasitic infections.
Yeah. Specifically, those with a tissue migration phase. We'll discuss this more in Section 3, but always check the eosinophils.
What about markers of systemic organ involvement?
Urea and electrolytes are essential to check renal function, which often gets hit hard by sepsis or Weil's disease. Liver function tests, LFTs, tell us about hepatitis or obstruction. And we must also routinely include an HIV-1 antigen antibody test.
Why is that so important up front?
Because a primary HIV infection can mimic infectious mononucleosis, and established HIV places the patient at risk for numerous other PUO causes. You have to rule it out early.
And for inflammatory markers, we have options: ESR, CRP, or procalcitonin. Do they all tell us the same thing?
They do not. ESR and CRP are general markers of inflammation. They rise late and fall slowly. CRP is generally preferred as it responds more acutely. Procalcitonin, however, is theoretically more specific for bacterial infection. PCT tends to rise quickly in response to bacterial toxins and falls rapidly with effective antibiotic therapy. So a very high PCT can push your suspicion heavily towards an occult bacterial source over a non-infectious cause like SLE.
We also need to cover that connective tissue risk immediately.
Absolutely. Autoantibodies, including antinuclear antibodies, ANA, and rheumatoid factor, RF, are necessary to cover that 15% PUO risk.
And finally, imaging and cultures. What are the bare essentials?
A chest X-ray and an ECG are baseline. Cultures must include urinalysis and urine culture, a throat swab, and critically, at least 2 sets of blood cultures, ideally collected before you even think about starting antibiotics.
That investigation list is hugely influenced by geography, isn't it?
Precisely. If the patient has any travel history to endemic areas, and this must be asked specifically, standard initial tests must immediately expand to include malaria films on 3 consecutive days.
Right.
A test for NS1 and suspected dengue, and often an abdominal ultrasound to look for liver or splenic lesions. The geography dictates your entire priority list.
Okay, we've established the PUO definition. Here's a check-in question for you, the listener. If a patient presents with a temperature above 38.0 degrees C every evening, but their fever resolves completely after 10 days of intensive investigation, can we apply the PUO definition?
The answer is no. Remember, PUO requires fever over multiple occasions for more than 3 weeks. If they resolved in 10 days, they had a fever of known or unknown origin, but they do not meet that strict, prolonged PUO threshold.
So that timeline is everything.
It is. If the timeline isn't clear, please rewind and review the PUO definition immediately.
Key takeaway 1.1. Fever's objective, 38.0 degrees C. The 38.0 degrees C gatekeeper. PUO requires prolonged investigation, the 3-week rule, and demands a systematic search across the PUO triple threat: infection, cancer, or connective tissue disease.
Moving on to another critical scenario where prompt action is literally life or death, a positive blood culture, or BSI.
Yeah, we're talking about massive mortality risk here, and we need to identify the culprit pathogen immediately.
BSI has an associated mortality ranging drastically from 15% up to 40%. The pathogen matters greatly. When a primary BSI occurs, meaning we cannot find an extravascular source like pneumonia or a UTI, it is most commonly caused by Staphylococcus aureus.
And that high rate of staph, aureus bacteremia, or SAB, is terrifying because of the metastatic complications, correct?
Absolutely. Community-acquired SAB is associated with infective endocarditis in 20 to 30% of cases,
Wow.
and osteomyelitis or septic arthritis in up to 10%. That high risk of seeding secondary infections alone mandates aggressive investigation, including an echocardiogram, usually a transesophageal echo, for higher sensitivity.
But before we panic and start aggressive treatment, we face that crucial first decision. Is this positive culture real, or is it merely contamination from the skin?
This is a fundamental point of critical thinking. Let's use our anchor here. Treat the blood culture result like an interrogation subject. You need corroborating evidence to trust it.
Okay, I like that, an interrogation subject.
The classic example is coagulus-negative staphylococci. If it's isolated from only one bottle, especially in an otherwise stable patient, it often just represents contamination from skin flora.
So what corroborating evidence makes us trust the interrogation subject? What makes it guilty?
Suspicion rises dramatically if you have repeated isolation of the same coagneg staph species from multiple culture sets drawn at different times, or, crucially, if the patient has any form of prosthetic material, a prosthetic heart valve, a joint replacement, a vascular graft.
Because it can stick to those.
These organisms are highly adept at forming biofilms on foreign materials. Their isolation in that context screams true infection.
What about other common suspects that might look like contamination but demand exclusion of serious disease?
Viridins streptococci often cause transient, non-significant bacteremia after, say, a dental procedure, but they are also a well-established cause of infective endocarditis, so you always have to exclude that diagnosis. Similarly, bacillus or Clostridium species often represent contamination, but certain species, like the highly virulent C. septicum, are genuine, life-threatening pathogens. That one is even associated with occult colorectal malignancy. We have to be aware of the exceptions.
Beyond the culture result, imaging remains vital, especially if we suspect Candida species infection or infective endocarditis.
Yes. The source explicitly mandates specific imaging. If we isolate Candida species, which is a pathogen prone to metastatic spread, fundoscopy after pupil dilatation should be performed immediately.
Immediately. Why?
Because of the high risk up to 40% of sight-threatening ophthalmic involvement, known as endophthalmitis.
That is an urgent, non-negotiable step that needs its own anchor.
Indeed. We will anchor this later in our fungi section, but the principle holds: CBC plus fever, eye exam. Every single patient with candidemia must have a full fundoscopy review.
Let's pivot now to a specific high-risk host. The injection drug user, or IDU, who presents with a fever. These patients require immediate focused attention because their history dictates a unique and dangerous set of pathogens and complications.
Fever in IDUs is complex. Due to non-sterile injection practices, they are highly susceptible to localized infections like skin abscesses and cellulitis, but also systemic spread causing septic arthritis and, critically, endocarditis.
Right.
Because they often inject into the superficial venous system, the organism bypasses the pulmonary circulation and commonly seeds the right side of the heart, primarily involving the tricuspid valve.
Which pathogens dominate this population, necessitating empirical coverage? What are we treating for right away?
Staphylococcus aureus is the primary pathogen, and you must must always consider both methicillin-sensitive, MSSA, and methicillin-resistant, MRSA. But in this population, you also see Pseudomonas aeruginosa, Candida species, and Viridin streptococci.
Given the severity of Staphylococcus endocarditis, what is the required empirical management while you're waiting for sensitivity results?
Empirical therapy must target Staph aureus immediately. This is typically an anti-staphylococcal penicillin, like flucloxacillin. However, if the patient has risk factors for MRSA, or if MRSA prevalence is high in the community, you must initiate a glycopeptide like vancomycin immediately.
You can't wait.
Delaying specific cover for Staph aureus is lethal.
And the treatment durations for endocarditis are one of those clinical details that medical students just have to memorize because they dictate months of patient care.
The difference is striking and high yield. For uncomplicated right-sided MSSA endocarditis in an IDU, the standard duration is high-dose intravenous flucloxacillin for 2 weeks.
Just 2 weeks.
But if it is MRSA endocarditis, the required duration is doubled, requiring 4 weeks of intravenous vancomycin. Specialist infectious disease advice is always needed, but you must know that 2 versus 4 week split.
Let's lock in that difference with a check-in question, listener. Which specific treatment duration is shorter for uncomplicated right-sided endocarditis in an IDU? MSSA or MRSA?
The answer is MSSA at 2 weeks. Remember that MSSA gets the shorter course of 2 weeks of flucloxacillin versus 4 weeks of vancomycin for MRSA. If you miss the difference, reinforce that 2 week versus 4 week split immediately, as it is a core management principle.
Key takeaway 1.2. Blood culture results need critical analysis. Is it the interrogation subject or contamination? Fever in an IDU demands immediate empirical cover for Staph aureus with aggressive investigation for endocarditis septic arthritis, remembering the shorter 2 week treatment for MSSA endocarditis.
Okay, so we've mapped out the geography of fever. Let's shift gears and look at the common causes that often present systemically.
Right, starting with the viruses that give us the classic defining rash, the childhood exanthems.
Childhood exanthems are characterized by a fever and a widespread rash. While maternal antibodies usually provide protection for the first 6 to 12 months of life, inadequate vaccine uptake means these diseases continue to pose a threat.
Yeah, allowing for outbreaks in susceptible populations. Starting with measles or rubiola, this is still a catastrophic disease in parts of the world.
Absolutely. Measles remains a global public health threat, which is why the WHO objective is global eradication using the live attenuated vaccine. And the source stresses that herd immunity requires greater than 95% uptake to prevent outbreaks.
95%. That's a high bar.
It is. The disease mechanism is complex. The virus causes severe immunosuppression, making the host vulnerable to secondary infections.
And those complications are severe.
They are. The mortality comes primarily from secondary bacterial infections, particularly pneumonia and diarrheal disease. Encephalitis is also a grave concern, sometimes occurring years later as subacute sclerosing panencephalitis, or SSPE.
If someone non-immune is exposed, what's the protocol? What do we do?
Passive prophylaxis with immunoglobulin therapy is used for high-risk non-immune contacts, so specifically immunocompromised patients or non-immune pregnant women. It has to be administered within 6 days of exposure to effectively attenuate the disease severity.
Next up, rubella, or German measles. The infection itself is usually mild in children, but the fear lies entirely with the pregnant host.
Precisely. The key threat is transmission during the first trimester of pregnancy. It carries up to a 90% risk of neonatal damage if it's acquired early.
90%.
This leads to congenital rubella syndrome, or CRS, causing a devastating triad of developmental abnormalities: damage to the eyes, the CNS, and the limbs or heart. Prevention focuses entirely on ensuring MMR vaccination coverage in women of childbearing age.
Now, parvovirus B19, also known as fifth disease or erythema infectiosum, it's highly common, but its presentation is distinctive.
It is. Parvovirus B19 spreads by the respiratory route and is extremely prevalent. In small children, the classic presentation starts with a mild fever and cold-like symptoms, followed by that pathognomonic sign, the intense characteristic slapped cheek rash on the face.
Right. And in adults, it's different.
In adults, the rash is less common, and it often presents instead as a polyarthropathy, so pain and stiffness in the small joints.
Let's get into the pathology here, because the rash is almost a distraction from the virus's real internal target.
That's a great way to put it. The virus has a specific tropism for the erythroid precursors in the bone marrow. It causes a transient but complete block in red cell production that lasts about 7 to 10 days.
So for a healthy person, that's no big deal.
Exactly. Their long-lived red cells compensate easily. But in certain patients, this block is catastrophic.
Or those high-risk patients.
First, the fetus. In a non-immune pregnant woman, this transient block can cause severe fetal anemia and lead to 10 to 15% of non-immune hydrops fetalis. That's generalized edema and fluid accumulation in the fetus due to heart failure from severe anemia.
So devastating.
Second, patients with chronic hemolytic anemias like sickle cell disease who rely on constant red cell production can suffer an aplastic crisis. And third, the immunocompromised, who can't clear the virus and develop persistent viremia, leading to chronic anemia.
We need to anchor that mechanism. The visible slap-in-the-face sign for the rash conceals the virus's real target, the bone marrow factory, the red cell precursors.
That analogy perfectly captures the high-yield risk. Management is usually supportive, but persistent viremia in immunocompromised patients can require immunoglobulin therapy to help clear the infection.
Finally, varicella zoster virus, VZV. The initial infection is chickenpox, but we need to focus on its reactivation state, shingles.
VZV is a herpes virus that establishes latency immediately after the primary infection. It just hides, in a non-replicating form, within the dorsal root ganglion of sensory nerves.
And then it comes back.
Years later, often triggered by stress, aging, or immune compromise, it causes intense burning discomfort along the affected dermatome, followed by the eruption of characteristic vesicles 3 to 4 days later.
The complications of shingles demand clinical urgency.
The most critical complication is involvement of the ophthalmic division of the trigeminal nerve, or V1. If vesicles appear on the tip of the nose Hutchinson sign, it strongly suggests V1 involvement.
And that's an emergency.
It is a medical emergency requiring urgent ophthalmology review because the virus can cause severe corneal ulceration, leading to blindness if not treated with systemic antivirals immediately. We also see Ramsay-Hunt syndrome, which includes facial palsy and a rash in the ear.
Time for a checkpoint. Listeners, you see a child with a slapped cheek appearance. What is the most serious non-immune consequence of this infection if it were acquired by a non-immune pregnant woman?
The answer is hydrops fetalis. It's due to the transient block in erythropoiesis caused by the virus's tropism for the bone marrow factory. If you miss the fetal risk, please revisit the parvovirus B19 pathology immediately.
Key takeaway 2.1. Exanthems are distinct. Rubella, severe congenital risk. Measles, high mortality complications requiring 95% vaccine uptake. Parvovirus, marrow suppression, slap cheek. And VZV, dermatomal reactivation, V1 ophthalmic emergency.
All right, now we move on to systemic viral infections that don't typically announce themselves with a classic rash, starting with mumps. Mumps is usually characterized by tender parotid gland enlargement, which is bilateral in about 75% of cases. The median incubation period is about 19 days. It's usually a straightforward diagnosis, but we have to watch for systemic spread.
What are the main complications a future doctor needs to worry about, and can they happen silently?
They absolutely can happen without visible parotitis, which makes them easy to miss. Meningitis complicates up to 10% of cases, usually mild, but critically, approximately 25% of postpubertal males develop epididymo-orchitis, painful swelling of the testes.
And that can lead to sterility, right?
While testicular atrophy can occur, clinical studies show that sterility is actually unlikely, which is a very important piece of information for patient counseling.
Next, influenza. The clinical impact of the annual flu season is entirely dictated by the virus's ability to constantly change its genetic makeup.
That mechanism of variability is critical. Influenza is caused by type A or B viruses, defined by their surface proteins, hemagglutinin, H, and neuraminidase, N. The severity is dictated by two terms, genetic drift and genetic shift.
Let's clarify that distinction using the analogies we rely on. What's drift?
Genetic drift refers to minor, port mutations in the H antigen gene. Think of it as an annual software upgrade or a new paint job on a car. These minor changes mean our existing immunity is slightly less effective, leading to the yearly seasonal epidemic.
And genetic shift is the big one.
Genetic shift is the major switch, the complete replacement of an H or N antigen or both. This is like a complete blueprint change, a brand new model of car. Few or no people have pre-existing immunity, leading to a high attack rate and the potential for a life-threatening global pandemic like we saw with H1N1 in 2009.
and the management hinges on that critical treatment window for antivirals.
Treatment is primarily supportive, but neuraminidase inhibitors like oseltamivir can reduce the duration and severity of symptoms. However, to be effective, they must generally be started within 48 hours of symptom onset, before the viral load peaks.
48 hours, a tight window.
It is. This window is sometimes extended in high-risk immunocompromised patients, but for most people, it's a hard stop.
Finally, infectious mononucleosis, IM, or glandular fever, caused most often by the Epstein-Barr virus.
EBV is another gamma herpes virus. When primary infection is delayed until adolescence or early adulthood, about 50% result in the classic IM syndrome, a severe triad of pharyngitis, high fever, and non-tender cervical lymphadenopathy.
And it's transmitted by saliva.
Hence the kissing disease nickname. Yes.
The complications of EBV are significant, especially those associated with activity restriction.
Common complications include severe pharyngeal edema, hepatitis, and critically splenomegaly. The risk of splenic rupture, a life-threatening hemorrhage, means patients must strictly avoid contact sports and heavy lifting until the splenomegaly has resolved.
Which requires careful monitoring.
Clinical and potentially radiological monitoring, yes. Long-term EBV is also strongly associated with specific cancers, notably Burkitt and Hodgkin lymphomas.
Now, for the classic high-yield error that every student must anchor in their memory regarding IM, the drug interaction.
This is the EBV trap. The source notes that a non-allergic, widespread, often itchy maculopapular rash occurs in a massive 80 to 90% of patients who are mistakenly given ampicillin or amoxicillin because their pharyngitis was misdiagnosed as bacterial strep throat.
So why does the rash happen? Is it a true penicillin allergy?
It is not a true IgE-mediated allergy. It is a hypersensitivity reaction specific to the presence of amoxicillin in the setting of an active EBV infection. It must be avoided, as it causes massive distress. But critically, it does not necessarily preclude the patient from receiving penicillin group antibiotics later in life.
That distinction is vital.
It is.
Check-in time. A patient with IM is mistakenly started on amoxicillin for a severe sore throat and develops a widespread itchy rash. What is the cause of this rash, and does it mean the patient is allergic to penicillin?
It is an antibiotic-induced rash resulting from the interaction with amoxicillin in the setting of IM. It occurs in a very high percentage of patients, but is not necessarily a true lifelong penicillin allergy. If the EBV trap is missed, reinforce this high-yield error and the need to strictly avoid ampicillin amoxicillin in patients with suspected EBV.
Key takeaway 2.2. Mumps causes parotitis and orchitis, sterility unlikely. Flu involves genetic shift drift, requiring antivirals within a 48-hour window. EBV causes IM syndrome, watch for splenic rupture, and critically avoid ampicillin due to the EBV trap rash.
All right, so now we are broadening our view, stepping into the realm of pathogens that demand a comprehensive global travel history.
Right, requiring us to think outside the immediate community environment.
If a patient has an undiagnosed fever, the travel history isn't just a formality, it is a mandatory public health interrogation. You have to know every country visited, the environment.
Was it urban, rural, near caves, near fresh water?
Exactly. Lodging specifics, activities, insect bite history, and detailed immunization status. The travel history limits your differential exponentially.
And once we've interrogated the patient, one specific lab finding gives us a huge early clue for a large category of tropical diseases: eosinophilia.
Defined as an eosinophil count greater than 0.4 by 109 per liter. Eosinophils are highly specialized immune cells. We need to remember that they are critically important in the immune response to parasitic infections, specifically those multicellular parasites, or helminths, that have a tissue migration phase.
Let's anchor that function. Eosinophils are the parasite grenadiers, mobilized when a large physical invader, like a worm or larva, is moving through the host tissue.
Exactly. They contain highly toxic granules used to attack the surface of these large invaders. Therefore, in the context of travel to the tropics, eosinophilia is a major indication to investigate for parasitic causes, like schistosomiasis, hookworm, or strongyloids.
And what about malaria?
That's a key distinguishing point. Malaria, being a protozoan confined mostly to the blood, rarely causes significant eosinophilia.
Now let's dive into some key viral threats for travelers, specifically the flaviviruses. Dengue is possibly the most important mosquito-borne viral threat globally.
Dengue is caused by a flavivirus and transmitted primarily by the urban Aedes aegypti mosquito. It causes breakbone fever because the generalized pains, myalgia, and headache are just so severe.
Where does the clinical danger lie? What's the thing to watch for?
It lies in the fluid dynamics. The period 3 to 7 days after the onset of fever is the critical phase. This is when signs of severe dengue hemorrhagic fever or dengue shock syndrome may develop due to plasma leakage from leaky capillaries.
And there were warning signs.
Yes. Increasing hematocrit, which suggests hemoconcentration and plasma loss, mucosal bleeding, and severe abdominal pain.
So management in that critical phase is everything.
It is entirely focused on managing fluid replacement to counter the shock from plasma leakage while avoiding fluid overload. Aspirin and NSAIDs are strictly contraindicated due to the severe bleeding risk. Getting that fluid balance right determines whether the patient lives or dies.
Yellow fever is another flavivirus, but it damages a different major organ.
YF is mosquito-borne, found in jungle cycles in South America and Africa. The illness is often biphasic: initial fever, myalgia, and headache. Then, in severe cases, the fever recrudesces, accompanied by jaundice, hence the name yellow fever, severe liver damage, DIC, and internal bleeding.
Given the liver damage and bleeding risk, what is the crucial contraindication?
Liver biopsy. It is absolutely avoided due to the risk of fatal, uncontrollable bleeding. The diagnosis must rely on serology and PCR. Prevention relies entirely on the YF vaccine.
Finally, Zika virus, infamous for its profound impact on fetal development.
Zika is a flavivirus transmitted by the Aedes vector, but what differentiates it clinically is its highly efficient non-vector transmission. It is transmitted sexually through semen and vertically from mother to fetus.
And while it's mild in adults,
The risk to the pregnant woman is immense. Infection during pregnancy leads to congenital Zika syndrome, causing devastating neurological defects in infants, including microcephaly, cerebral calcification, deafness, and visual problems.
and the sexual transmission risk is long-lasting.
It is. Due to the persistence of the virus in semen, infected individuals, even if asymptomatic, are advised to practice safe sex for at least 6 months to prevent sexual transmission to a partner who may become pregnant.
Key takeaway 3.1. Eosinophilia is the parasite grenadier clue for tissue-migrating parasites. Dengue and YF are flaviviruses with high hemorrhagic potential. Zika is infamous for its severe teratogenicity and dual transmission routes.
We shift our attention now to important bacterial diseases, particularly the Spirochetes bacteria, characterized by their flexible spiral shape.
Right, highly modal and have complex multi-stage presentations, starting with Lyme disease, caused by the Spirochete Borrelia burgdorferi and transmitted by ticks. The clinical presentation is classically split into 3 distinct stages.
Stage 1, the early localized disease, is defined by the unique rash, erythema migrans. This appears 2 to 30 days post-bite as a red macule or papule that slowly enlarges peripherally, often clearing centrally to produce the distinctive pathognomonic bullseye sign.
And the diagnosis at this stage is purely clinical. You see the rash, you treat.
Yes. The presence of the EM rash in an endemic area is diagnostic. Serology at this stage is often negative. If that initial stage is missed or ignored, it progresses.
What happens in early disseminated disease?
The Spirochete spreads systemically via the blood and lymph. Patients develop lymphocytic meningitis, cranial nerve palsies, most commonly unilateral or bilateral facial palsy and carditis, which typically manifests as serious AV block.
And the final, late disease.
This occurs months to years later, characterized by a chronic inflammatory state causing recurrent arthritis, particularly affecting large joints like the knee, and chronic neurological involvement or encephalopathy.
How does the stage of the disease impact treatment? It must change pretty dramatically.
It does. Early localized EM is treated simply with a course of oral doxycycline. However, once the disease has disseminated, specifically involving the CNS or causing high-grade AV block, you must use parenteral beta-lactam antibiotics like ceftriaxone, typically for 3 to 4 weeks.
You can't rely on oral therapy for neuroborreliosis.
You cannot.
Next, leptospirosis, a zoonosis tied to water contamination.
Leptospirosis, caused by L. interrogans, is a global zoonotic threat, particularly in tropical climates and after flooding events. The common reservoir is the rat, which sheds massive amounts of the organism in its urine.
How do humans typically acquire it?
The Spirochetes can penetrate intact skin, but infection is facilitated by prolonged immersion in contaminated fresh water, especially if the skin has cuts or abrasions. Think about occupational exposures like sewer workers or farmers, or recreational exposures like canoeing or swimming in fresh water.
Right, the anchor is water sports and rat urine.
Exactly. Most cases are mild, non-specific bacteremic illness, but the severe form, occurring in about 5–10% of patients, is known as Weil's disease.
And what does that look like?
This is a multi-system failure characterized by profound jaundice, acute kidney injury, a severe bleeding diathesis, and often myocarditis. It can be deadly.
Finally, plague, a disease requiring rapid recognition because of its extreme lethality.
Plague, caused by Yersinia pestis, is a gram-negative coccobacillus transmitted by rodents and fleas. It requires immediate suspicion, isolation, and treatment. The classic diagnostic clue is seen on microscopy.
And what's clue?
When samples are stained, Y. pestis exhibits bipolar staining, meaning it stains heavily at both ends, often described as having a safety pin appearance.
That safety pin image is a powerful anchor for laboratory recognition, and management must begin immediately, right?
Absolutely. Treatment with streptomycin or gentamicin must begin immediately upon clinical suspicion. Any delay is catastrophic.
Check-in question. A hiker in an endemic area develops a distinctive, slowly enlarging, ring-like rash 10 days after a tick bite. What is the name of this rash? What is the pathogen? And if this patient developed unilateral facial palsy 3 weeks later, how would the treatment regimen change?
The rash is erythema migrans, caused by Borrelia burgdorferi. If facial palsy or neuroborreliosis developed, treatment would switch from oral doxycycline to a parenteral beta-lactam like ceftriaxone. Ensure the listener has anchored the EM bullseye rash to Lyme disease and understands the shift in treatment for neurological involvement.
Key takeaway 3.2. Lyme is treatable if recognized early. Leptospirosis can be deadly, so look for water sports and rat urine exposure. Plague requires rapid recognition of the safety pin, coccobacilli.
We turn now to the pathogens that have redefined global public health in the 21st century coronaviruses.
And then we'll delve into the opportunistic infections that prey on the most vulnerable, immune-compromised host, particularly fungi.
Coronaviruses are single-strand positive-sense RNA viruses. While they generally cause mild upper respiratory infections, 3 have emerged from animal reservoirs in recent years as serious zoonoses: SARS-CoV, MERS-CoV, and of course, SARS-CoV-2.
And all 3 follow that classic zoonotic spillover model.
Yes. They all originated in bat reservoirs, often transferring to humans via an intermediate host, palm civets for SARS-CoV and camels for MERS-CoV.
Right.
The intermediate host for SARS-CoV-2 is still suspected to involve wild animals, with initial human exposure possibly occurring through contact with infected animals in food markets.
Let's discuss the critical pathogenesis of severe COVID-19. It wasn't just a simple respiratory infection, it was a systemic catastrophe for some patients.
That's the key distinction. The early mechanism involves a suboptimal early interferon response. The virus basically manages to shield its RNA from the host's initial pattern recognition receptors.
So it gets a head start.
This early failure allows the virus to replicate rapidly before the immune system catches up.
So the body's reaction is too little, too late, leading to an overly destructive response.
Exactly. We use the anchor. The immune system in severe COVID-19 acts like a delayed and overzealous firefighter. It arrives late to the scene, but then overreacts, releasing a flood of pro-inflammatory cytokines, the cytokine storm causing massive collateral damage in the lungs, heart, and brain.
What are the distinguishing clinical features we must remember beyond the basic respiratory symptoms?
The initial phase is marked by common features like loss of taste and smell, alongside headache, cough, and fever. Severe disease is defined by hypoxia, bilateral crackles, and frequent multi-organ injury. But the distinct feature that differentiates severe COVID-19 from a typical ARDS is the activation of the coagulation cascade.
That pervasive clotting risk is what makes this disease unique.
Precisely. The hyperinflammation activates the clotting cascade aggressively. This leads to high rates of VTE and microthrombi forming throughout the microvasculature, especially in the lungs.
And there was a specific term for that.
Yes, some experts propose the term microflots to capture this distinct pathology. This demands the aggressive use of prophylactic and often therapeutic anticoagulation.
The pandemic also forced us to relearn and strictly apply infection prevention and control rules, specifically regarding respiratory particle size.
Yes, the distinction between airborne and droplet transmission. IPC hinged on the 5 micrometer cutoff. Respiratory droplets are large, heavy, and fall quickly. Airborne or aerosol spread involves particles less than 5 micrometers that remain suspended in the air.
So how did this apply to COVID-19 management?
SARS-CoV-2 is believed to be predominantly transmitted by droplet spread in standard interactions. This means standard surgical masks and distance are generally sufficient. However, the transmission shifts to the airborne route when the patient is subjected to an aerosol generating procedure, or AGP.
What are the high-risk AGPs that force us to change our PPE?
Tracheal intubation, manual ventilation, tracheostomy, bronchoalveolar lavage, and certain high-flow oxygenation treatments are classic examples. During these procedures, healthcare workers must switch from standard droplet precautions to the more stringent airborne precautions, like an N95 respirator.
Finally, what is the unifying clinical feature of long COVID?
Long COVID, or post-COVID-19 syndrome, is defined by persistent symptoms lasting more than 12 weeks. The most common, universally reported unifying feature is prolonged, extreme, and often debilitating fatigue.
And brain fog.
Yes, usually accompanied by headache, memory problems, or brain fog, and persistent signs of organ dysfunction.
Here's your check-in question. When managing a severely ill COVID-19 patient, you notice they are becoming increasingly hypoxic and require emergency intubation. What procedure mandates switching from standard droplet precautions to airborne precautions for healthcare workers?
The answer is an aerosol generating procedure, AGP, such as tracheal intubation. This highlights the crucial clinical requirement to know the difference between droplet and airborne spread in an acute setting. If you forgot the difference, review the 5-micrometer cutoff and the list of AGPs.
Key takeaway, 4.1. Severe COVID-19 is defined by a clot and inflammation pathology driven by the delayed and overzealous firefighter immune response. IPC must differentiate droplet transmission from the airborne transmission triggered by AGPs.
Fungal infections are often the critical indicator of profound immune compromise or specific geographical exposure. They can be caused by yeasts, molds, or dimorphic fungi.
Let's look at acute disseminated candidiasis, or candidemia. This is an infection highly prevalent in acute care settings.
Candidemia, the isolation of Candida species from the blood, is extremely common in critically ill intensive care and surgical patients. The main predisposing factors are often related to invasive devices and nutrition.
Like CBCs and TPN.
Exactly. The presence of a central venous catheter, broad-spectrum antibiotic use, and total parenteral nutrition.
What is the single crucial high-yield clinical step that must be performed in every candidemic patient?
Due to the propensity for Candida to spread hematogenously, up to 40% of cases will have ophthalmic involvement, presenting as characteristic retinal cotton wool, exudates, and ophthalmitis.
Which can cause blindness.
It's a sight-threatening condition that leads to blindness, so all candidemic patients must have a full ophthalmoscopy review immediately.
This is a point of potential clinical failure if missed in the chaos of an ICU. We must anchor this aggressively.
This is our anchor. CVC plus fever easel eye exam. Every single candidemic patient must have a full fundoscopy review to catch those sight-threatening retinal exudates before permanent damage occurs. We should also remember that IDUs are also prone to candidiasis, often from contamination in the solutions used to dissolve heroin.
Finally, let's quickly cover the dimorphic fungi, which are defined by their ability to change form.
Dimorphic fungi are unique because they exist as mold in the cooler external environment, but they switch to the yeast form once they enter the warmer human tissue. Two key examples are histoplasmosis and coccidioidomycosis.
Starting with histoplasmosis.
Found predominantly in the Americas, particularly in soil contaminated by bird or bat droppings. It's acquired by spore inhalation. In immunocompetent patients, it's a mild flu-like illness. But in the immunocompromised, it causes severe disseminated infection, which dangerously mimics tuberculosis.
Mimics TB. How so?
With fever, weight loss, lymphadenopathy, and pulmonary nodules or cavitation, it can be a real diagnostic challenge.
And coccidioidomycosis, or valley fever.
Found primarily in the desert regions of the southwest U.S. The primary infection often presents as valley fever, a flu-like illness with cough, fever, a rash, and sometimes arthritis. And again, it can progress to severe disseminated disease in immunocompromised hosts.
Key takeaway 4.2. Systemic fungi are opportunists or geographically linked.
Yeah.
Candidemia must trigger an immediate ophthalmoscopy to prevent blindness. Remember, the CVC plus fever eye exam anchor.
We covered a tremendous amount of territory in this deep dive.
Yeah, from the necessary vigilance against contaminants in blood cultures and the non-negotiable need to empirically treat Staph aureus in IDUs, to the importance of recognizing the unique risk of viral scourges and avoiding the amoxicillin EVV trap.
We also anchored key diagnostic clues, like eosinophilia being the parasite grenadier clue, and delved into the complex mechanisms of global health threats like dengue and the unique clotting pathology of SARS-CoV-2.
Remember the fundamental framework as you approach any patient, especially those with an undiagnosed fever. Host, bug, environment. Infectious disease diagnosis is always about history first.
Always. You must consider the host's vulnerabilities, their immune status, their age, their travel history, before you even consider the specific organism. This structured approach will save you from getting lost in the overwhelming differential diagnoses.
We leave you with 3 final key takeaways to solidify this material.
1. Look for the pattern. Erythema migrans for Lyme, slap cheek for parvovirus, and the classic triad for IM. These unique signs are your cognitive shortcut to a diagnosis.
2. Act on the risk. Avoid ampicillin in patients with suspected IM. Check the eyes immediately in candidemia patients because of the high risk of blindness.
And know the 2-week MSSA versus 4-week MRSA treatment delineation for right-sided endocarditis.
And 3. Respect the environment. The critical distinction between droplet and airborne spread dictates the appropriate level of protection needed for healthcare workers, especially when performing life-saving, aerosol-generating procedures.
We've established how many of these diseases, from plague to the emerging coronaviruses, are zoonoses, spilling over from animal reservoirs due to proximity and environmental change.
Which leads us to our final provocative thought for you to explore. As global climate shifts, driving vectors like mosquitoes and ticks into new regions, and human activity continues to encroach on wild habitats worldwide, what is the next great zoonotic pathogen, already existing silently in its animal host, waiting to jump the species barrier and fundamentally redefine public health?
Thank you for joining us for this intensive deep dive into infectious disease essentials. Make sure you check your memory anchors and revisit any sections that felt shaky.
The clarity you gain now will be invaluable in your clinical career. We'll catch you next time.